So when we were looking at the curriculum for internal medicine residents and what you should know about psychiatry, we had a very lively discussion in our education department of, okay, so when we hear from other departments what's helpful for us, what makes it something that we walk away from the lecture thinking, oh, I got that. So part of the reason I am going after Dr. Casey is I've seen his lecture that he just gave you on the mood disorders. And so what I'm going to do with you today is sort of walk you through a patient. The patient comes to your office because some of you will be hospitalists, so maybe they come to the hospital and talk to you about this. But some of you will have private offices where probably half, if not more, of your patients will have some kind of psychiatric comorbidity. Whether they're diagnosed or they're not, they probably will have something that you should be thinking about and at least having general ideas of how to go about treatment. The other thing I know about psychiatry from not being a psychiatrist, but actually prior to medical school working in a psychiatrist's office, is the number one complaint in internal medicine is, why can't you take this patient? You know, it's very difficult to get patients in to see a psychiatrist. One, because there's not a whole lot of us. And two, because when you set up a psychiatric appointment, it's a timed appointment. And while that might not mean much to you, what I say to like my OB friends is, you know, I can't just squeeze 20 minutes in, or I can't squeeze a pap smear in between these other two people. The people that I have set into my schedule are set for that period of time. So it's very hard to squeeze people in. Now, we all know there's a no-show rate and all those things, but when they're setting on time, it makes our schedule a little less fluid. So we're going to talk about this case, and this case is going to have lots of interesting things that happen to one poor little person, but it's more to talk about basic ideas. So this is a 33-year-old white female. She comes to your office. She's sad, lots of somatic complaints, tension like headaches, some GI distress that's coupled with some constipation at times. She's had some stressors lately. Her boyfriend of 3 years and she broke up, and her dog just died. So what do you want to know about this patient? And you're looking at her and she looks a little sad.
When did she break up and when did her dog die?
Within the last couple months. So all this is sort of new stuff for her. What else do you want to know?
Changes in sleeping and eating.
Okay. She hasn't been sleeping as well. Her appetite fluctuates. She hasn't really noticed that, you know, most people, although women probably more than men, but don't really know if they've gained or lost weight. So a lot of times I'll ask them, are your clothes tighter or looser? Most people can answer that question a little better. What else do you want to know?
Does she feel like hurting herself or other people?
Oh, what a good question. You always have to check for dangerousness. And no, she's not suicidal. She's not homicidal.
Does she have intolerance to cold, hair loss, things like that?
Oh, now you're talking like an internal medicine doctor. You want to know if there might be some sort of medical problem going on. For this case, no. Anything else you want to know?
Past medical history, she's been depressed before.
You know, she's struggled on and off throughout her life, but never really felt like she felt this bad.
No other medical problem.
No.
Substance abuse.
No substance abuse problems.
You want to know the duration that she's been sad? How long has she been sad?
Probably for the last couple months. One of the other interesting things about timing, particularly when you're looking at, so what do we think we're looking at here? You just had a whole lecture on depression. What do we think we're looking at here?
Grief versus depression versus some sort of.
Yeah, so one of the things about depression timing that I think is really important to know is if you look at the criteria, theoretically, they're supposed to be depressed for 2 weeks, unless they're suicidal, and that sort of kills the timing, and you sort of go to the main diagnosis of depression. You know, it's interesting because there more and more people at least come to my office, and I suspect you guys see as well, who will talk about depression. Well, I feel bad, I feel sad for a couple days, and then I'll have a day or two that I feel okay, and then I'll feel sad for a few more days. And that gets trickier, not because they're still not sad or depressed, but they don't clearly meet criteria. And the interesting thing about criteria is sometimes they can really tell us a lot about whether they're going to respond to medication. Has anybody really felt like they've met somebody that you thought, wow, this person doesn't just have a crazy life, they have a really deep biological depression? Have any of you guys seen that? The type of person that when you walk in the room, the depression sort of hits you in the face. None of you guys have seen it? Well, Dr. Parker, none of you guys have seen that. The first time you do, it will make an impression. But I think that that really speaks to the fact that depression has sort of become a lingo, you know, oh, I'm depressed, and it's more popular. And a lot of the depression that we see is very much psychosocial. People are living crazy lives and they can't figure out why, holy cow, I don't feel good. So we're going to say, she tells us she might be depressed, and I think we talked about the energy. So basically some of the questions you guys asked were that SIGI caps that we learned in medical school of looking at whether somebody meets criteria. So does this lady need medication? I can promise you most people who come to your office are going to want medication. And so you have to figure out where you stand on whether to medicate or not medicate. So some of the best ways of knowing whether medication is going to work, people with the depression that you can sort of feel when you walk in the room tend to respond very well to medication. People who have the neurovegetative signs of depression tend to respond very well to medication. People who have, I'm depressed a couple days, then I'm okay a few days, tend to not respond as robustly to medication. And so what would you do with this lady? She has some somatic complaints along with, you know, some pretty significant depressed mood feelings. Would you give her an antidepressant?
I don't think she technically meets criteria.
Okay. What if she says, I've never felt this bad before, doctor, why can't you give me a pill? I saw that ad on TV. It said it'll make me feel better. It'll make it easier to get out of bed. So most of the time people get treated. Whether that's the right thing or not, I don't know that we have enough time to debate the philosophical ideas behind that. But let's say, yes?
So I have a question about that.
Yeah.
If she doesn't meet depression criteria, so for example, in our computer system, I can't put in a diagnosis of depression.
Right.
So how can I get any insurance or anything to pay for an SSRI if she has no diagnosis that's related to that?
So you can use a different diagnosis. So the lighter diagnosis from major depression is depressive disorder NOS, which basically means you don't think they have major depression, but you think there's something going on. Or, you know, the catch-all forever is mood disorder NOS, which just means, holy crap, I don't know really what's going on, but they have a lot of affective instability. A lot of those patients with mood disorder NOS end up having personality issues as well. Yes, sir?
Does she meet criteria for adjustment disorder versus depression?
Good question. So she possibly could be adjustment disorder with depressed mood because most of the onset of these symptoms happened, you know, with the breakup and her dog dying. Very good. So again, as internal medicine doctors, I don't know that you have to memorize every diagnosis in the psychiatric books because you probably have enough other things to remember. But adjustment disorders are fairly common, along with, again, major depression, and then depressive disorder, NOS, is a good one to know if you don't think they meet the criteria. But you think, gosh, would this person at least benefit from a trial? And let's say you've known this girl, you've been her doctor for the last 10 years, and she walks in and you've never seen her really look like this. You know, you're just like, wow, sort of the light's gone from her eyes, she's not interacting in the same way. You know, that might make a different impression on you than somebody who walks in for the first time and is like, doctor, I just want a pill. And I think that's one of the things that as you finish residency and begin seeing patients that you get to know over time, you notice the changes in them much easier than sort of the way residency sets up our patient flow sometimes, where you're like, you're lucky if you get to see the same person, you know, over time during the course of your treatment. So we're going to decide to give her an SSRI just, and again, I would still be on the fence whether she needs one based on the case, but this is just more for discussion's sake. So which one of the SSRIs would you choose, and why would you choose it? Can anybody name an SSRI?
I'll pick Zoloft.
Okay, you pick Zoloft. Do you have any reason why you pick Zoloft?
If you want me to be honest, because the guy before you said that he always picks it first.
Okay, that's a good reason. The guy before me is a very, very good clinician, so I might start picking it first as well. So Zoloft's fairly well tolerated. In our system, it's on the formulary where patients can afford it, which is somewhat important. The most common side effects with Zoloft are, did he tell you this? So GI and headache within the first few days. So usually you want people to take it with food. And this is the SSRI class overall. And the headache will go away if they get it. They just have to make it through the first 3 days of treatment, and usually it goes away. What's a longer-term side effect that you should probably tell patients about when you're talking about SSRIs? Absolutely. Sexual side effects. Most patients are going to have a very difficult time talking to you about sex if you don't mention it first. 30 to 40, some of the studies even say 50% of patients who take SSRIs will have sexual side effects because of the medication. Now, some of these patients were having sexual side effects because of their depression and because of some of the other issues going on in their life before they took an antidepressant, but it is important to know that sexual side effects are very much a part of this class of drugs. So maybe Zoloft. People know the dosing ranges just because you guys are going to see lots of these patients. Usually a starting dose is 50. Most people who have clear major depression, you end up getting them to a 200 milligram dose for effectiveness. But usually you can go up by 50 to 100 depending on sort of the severity that you think they're presenting with. What other SSRI might you consider? Lexapro. Okay. Any reason why you chose Lexapro other than it's in the class? So, yes and no. Lexapro is one of the newer medications, so for most of our patients, when you're looking at how they afford their medications, they cannot afford Lexapro. Citalopram or Celexa is the enantiomer of Lexapro, and it is covered and you don't have to do a pre-authorization to get it filled. So most of the time within our system we use Celexa. They're very similar. So citalopram and escitalopram are Celexa and Lexapro. Again, usually well tolerated. The good thing about Lexapro, particularly if you have a patient who's really, really anxious with their depression, because there is a subset of sort of the depressed, anxious patient, Lexapro tends to be tolerated very well in that group. and you start them on anybody who has anxiety with their depression, a lot of times you want to start a lower dose and increase their dose much more slowly than you would just a strictly depressed person, because the increase in serotonin can make them more anxious. So if you do a lower dose and start and increase it more slowly, they tend to tolerate it better. So Lexapro is an option. What else is in that class?
What's the sleep pattern like?
I'm sorry?
What's the sleep pattern like? Does she sleep well?
She's having some problem with sleeping. Okay. And why would you say that? Okay, so Prozac tends to be a little more stimulating, and Paxil tends to be a little more sedating. Might there be, so I use very little Paxil in women because if you remember from medical school, again, Paxil packs on pounds. It's probably the most, of the SSRIs, the most weight gaining of that class of medication. And most women, their first question is this medicine going to cause me to gain weight? The other thing, and this is in one of my further slides, but I'll tell you now because you brought Paxil up. The other thing is this is a woman of childbearing years, and unless we're sure of her contraceptive planning, which 50% of the babies in the United States are oopsie babies, so I'm not sure we can trust anybody's contraceptive planning at this point. Paxil is the only Class D medication of the SSRIs for pregnancy. It has an increased risk of ventral septal defects and lots of class action lawsuits associated with Paxil currently. So, you know, it's a good medication for, again, the patients who are pretty anxious and can't sleep at night, but you have to be aware of the risk if you're wondering whether, you know, they're going to get pregnant on this medication. Okay, so we pretty much covered Paxil, Prozac, Zoloft. We did another, and then the Lexapro and Select. So those are the most common SSRIs that are used. So let's say we chose that medication and it didn't work. So we'll start with Zoloft because Dr. Casey says we always start with Zoloft. And then we maximize the dose to 200 for her depression and it doesn't work. What do you do next? Pardon? Okay, so one option is to do a trial of another SSRI, which is reasonable. What else? Okay, so your next option would be to trade to a whole different class of medication. So sort of the next layer of class of medications we have are the SNRIs, and then we have Wellbutrin, which is sort of its own little class itself. So what would you think about, why would you choose Wellbutrin over an SNRI? Do you know the differences between the two? Okay, so Wellbutrin hits norepinephrine and dopamine, and then obviously SNRIs are serotonin and norepinephrine. Again, Wellbutrin is one that if you have any anxiety at all, it can really be stimulating for people. One of the other indications for Wellbutrin is for adult ADHD. So we know that it works and can be very stimulating to our patients. So in this particular lady, Wellbutrin might be a good option, particularly if she's having a hard time getting out of bed in the morning. You know, the people who are depressed that just are dragging all day, Wellbutrin's a fabulous option for them. The SNRIs tend to work really well for people sort of with the mixed depression anxiety picture. In starting SNRIs, they can also get a little more anxious. Do people know what medicines are in the SNRI class? Effexor and what else? Cymbalta. So you guys probably know Cymbalta is associated with helping with pain, so fibromyalgia patients really like Cymbalta. The thing they don't tell you a whole lot about with the Effexor and to some extent the Cymbalta, but particularly the Effexor, and Effexor now has a new sort of the next generation Effexor, which is Prestique. And there's also Vibrid, which is sort of the newest of the SNRIs. Effexor is, it has a very, very difficult withdrawal syndrome. So if you start somebody on Effexor and you stop their Effexor right away, they will not like you a great deal and probably call you a great deal because they will feel like they have the flu, like they've been hit by a truck and the truck backs up and keeps sort of running over them. And that withdrawal can last up to a week. Some people are so sensitive to Effexor that if they miss their dose, if their dose is not within an hour or two of each other, then they start feeling the withdrawal symptoms, even with the Effexor that has the extended release. And I tell you that just because it's like sometimes when our patients call, you're like, it can't be that sensitive, but there's absolutely a withdrawal phenomenon with the Effexor that can start very, very early. So again, I try to stay away from Effexor. There are some people who tolerate it very well, but for those who don't, if you ever have to get them off of it, it is a long and painful process for everybody involved. So what if your SNRIs and your bupropion don't work? What can you try? You can add what? Okay, so what would you add as a booster? Okay. Yeah, there's a lot of old studies that talk about thyroid augmentation. Lithium is a good augmentation strategy, and antipsychotics. So the most common thing, again, and I'm trying to say common things that I see from primary care doctors when they come to me, is a lot of people will use low doses of the atypical antipsychotics. So for their patients who can't sleep, they'll give them Seroquel at nighttime. For the patients who come in and quote the TV commercial, they'll give them Abilify during the day. Those are the two most commonly used adjuncts that I see. What would you worry about in giving a depressed patient an atypical antipsychotic? Yeah, so there's a metabolic syndrome that's associated with the atypical antipsychotics. Very good. So it's not only the insulin and glucose, but it's their lipids and triglycerides. It can make people sort of, well, if you look at the chronic schizophrenics, they all sort of start beginning to have the same body habitus. I don't know if you guys have watched that, but so they get really, really large waist circumference and lots of metabolic problems from their medications. What else might you worry about with the atypicals? So I think people have gotten very, very comfortable with using the atypical antipsychotics, and I don't want to dissuade you from doing that, but in people with mood disorders, they are more likely to have some of those old things we don't see as much, but tardive dyskinesia and abnormal movement problems than people who are psychotic that we use the antipsychotics for. So being aware that particularly Abilify can cause akathisia, and you might not see it. Do you guys know what akathisia is? Yeah, so it's that need to keep moving. And so some of these patients you'll see in your waiting room, and they'll be pacing all over the place, and you'll be like, holy cow, what is wrong with them? And so it's sort of right there, and you know to ask about it. But akathisia can also be an internal feeling, and the patients will come in and say, you know, it feels like my insides are just shaking, and I can't stop that. That's the same thing. So to treat akathisia, you can give them obviously change medications. You can try to lower the dose, but some people just can't tolerate the atypicals because of that. The other adjunct of Seroquel, obviously sedation is one of the good/bad side effects depending on whether you can or can't sleep. The other thing to remember, particularly in the elderly, is it has a very strong orthostatic hypotension. So for your patients who are more likely to have falls, being aware that you can improve their chances of falling by giving them Seroquel in the evening. The other thing to know is that Seroquel has a street value because people crush it up and snort it. So Seroquel is one of the ways to come down when you've been tweaking off meth or any number of other things that you might be tweaking off. They use the Seroquel basically to put themselves to sleep. So in your chronic drug abusers, Seroquel might not be the atypical antipsychotic that you want to use. So we're going to sort of go back to this case and now twist it a little bit and say, you know, so what happens if you give somebody an SSRI and they come in and you've made them worse? Because again, we became doctors because we want to make people better. So our patient comes back, her speech is pressured, she looks a little disheveled, she's talking about her startup company that she's been working on the past few days and convinced that she is going to make millions of dollars with her plans to sell multicolor shoelaces that will change colors based on one's mood, sort of like the old mood rings. What do you start thinking now? Besides, holy crap. So mania. So if you make somebody you don't make people manic. If somebody becomes manic because you gave them an antidepressant, does that necessarily mean they have bipolar disorder? Anybody want to guess? Theoretically, the answer is no, that it's a drug-induced mania, even if it is a medication that you've given them. However, most people that the SSRIs make them manic truly had bipolar disorder in the first place. So you've basically unmasked it. So what do you do if somebody comes in, you've started them on an SSRI, and they become manic? Stop your medicine. I saw that being mouthed. Anything else? Pardon? Refer to a psychiatrist. Very good, but oh gosh, you can't get them in for 3 months. And she really thinks, I mean, she's invested $100,000 of her own money into this multicolor shoelace company that I suspect we all know isn't probably going to make her millions of dollars. Okay. And why would you start with lithium and Depakote? Absolutely. And actually, they're the first line medicines for people who are manic. Probably lithium is the oldest and cheapest and probably the best medication for people who are manic. The good thing about Depakote is you can do a loading dose of Depakote. So if you think, you know, in the hospital or in your office that somebody's really manic and potentially violent, you can choose their dose by figuring out 30 milligrams per kilogram. So people say anywhere from 20 to 30 milligrams per kilogram is a loading dose of Depakote. So you're no longer guessing how much medicine they're going to need to be therapeutic and hopefully become not manic. Whereas most of the time on lithium, we pick the starting dose of 300 milligrams twice a day, wait till we get a level, and then we can sort of decide how high up to go. Do you guys feel like as internal medicine doctors, you would be comfortable prescribing lithium? I think no is a fair answer. I think in your lifetime, you probably will at some point, just because there are lots of sick people out there. I think once you start looking at people who are glaringly manic in your office, you are looking at a referral to a psychiatrist. So you need to make a good friend with one of your classmates who went into psychiatry so you have a referral base that you can say, hey, I really need to get this person in. But I think that a lot of times treatment does start in their primary care office. And so at least being comfortable with the starting doses and dealing with the medications that are associated. A lot of times once patients are stable on their psychiatric medicines, some just want to come see their psychiatrist, but most of them are tied to you all. You know, when a lot of my patients, their primary care doctor is their doctor. And they like me just fine, and we do good work together. But when they can go back and just deal with their primary care doctor, that is actually a lot of times their preference. And so sometimes I'll call the primary care doctor and say, look, you know, they've been stable for the past year on this medication. Are you comfortable prescribing it? And if not, we'll talk about that. And, you know, I don't care to continue to see patients. Once you know them, they're fairly easy to take care of. But that also keeps my schedule a little more open as new patients come. And so if people are stable, I do try to send them back to their primary care doctor. Yes, sir.
So you mentioned about this Paxil
Mm-hmm.
with the pregnancy test.
Mm-hmm.
So if you're worried this lady could get pregnant, especially
Right.
that she's manic and she's probably hypersexual.
Mm-hmm.
I mean, lithium and Depakote were Depakote causes like neural tissue defects.
Right.
Lithium, I guess, was Epstein's phenomenon.
Yes.
So what would you do?
Well, so the thing is our patients always have their own choices that we don't have a lot of control over. The fact that you asked the question means you documented the chart, discussed the importance of contraception. Obviously, if there's a significant other in the picture, it's helpful to have that discussion with them present, particularly if somebody is manic. Prescribing birth control pills, which again, a manic patient does not take pills well. So any kind of longer birth control pill shot, I use a lot. I have a lot of patients who are on the shot because we can usually get them in to see their OBGYN 3 to 4 times a year. It's much harder to get them to take a pill every day. And there's Mirena rings. There's all this new contraception that's longer as well. So these would all be good candidates. So what I do within the Department of Psychiatry is I take care of pregnant women who have mental illness. So we don't use Depakote in the first trimester, if at all possible. Some people with seizure disorders don't have a choice, so they end up being on a mood stabilizer of some sort during their first trimester. The lithium is actually considered less scary than it used to be. When they really went back and looked at the studies on Epstein's anomaly, they think that that particular study had some bias and it overrepresented. But it's still absolutely a risk. People with very bad is not the right word. My kid was sick last night, so my word finding is a little messed up because I've been up most of the night. People with a chronic mental illness that have to be on treatment, what we do is we try to decrease the risk. And for some people, that means they have to take lithium in their first trimester. The other option sometimes is the atypical antipsychotics. There's a little bit of literature about Zyprexa. Zyprexa has a really good mood stabilizing component to it, but sometimes we use that in pregnancy because it's considered a little safer than the lithium or the Depakote. But again, it's never without risk. So the way to protect yourself is always to document, discuss there are risks if you become pregnant on this medication. And that's actually with any medication that you prescribe to women of childbearing years. All you can do is provide the information, and what people do with that information is not always what you would like them to do. But it does get trickier when you're like, so I need to treat this woman. She's manic. She's probably not going to make good decisions for herself. What do I do? What's the safest way? Sort of the caveat to that is a lot of times if we start them on a primary mood stabilizer, which you told me lithium and Depakote, and I should have said Tegretol is the third one. If we can get them non-manic, which usually happens fairly quickly with medication, then they're back to making better decisions for themselves. So it's just sort of that window of when they're in the midst of mania that sometimes gets tricky. But do the patients get pregnant on this medication? Absolutely. On every medication, I just had one last week that despite knowing she should not get pregnant on Depakote, decided that's what she wanted to do. So you give them folic acid and you talk with the OB and you set up things to be as successful as you can based on the circumstances you have. And I only mention the women's health part because that's what I do, but to also just have an awareness. Again, you can't always prevent what's going to happen, but having an awareness that that should go into your thinking. So you're right. Both of these medications are a little scary in the first trimester. And that's actually what we've been talking along about as we went through. And you know what? I walked out of my office, but I will send this to you to send out. The last sort of thing I wanted to cover with you guys today is, and just on this case, and then I was going to let you ask questions about sort of practical things you'd like me to answer for you, is what happens when you have somebody who comes in and is suicidal. Because I think everybody's first gut is to say, send them to the ER. And maybe that's the right thing to do 85% of the time. I think it gets harder when you start seeing patients that you've known and they're struggling. There's also the other group of patients that are always suicidal. You know, they chronically have thoughts of hurting themselves. And has anybody met those people? And I think it comes down to then how do you assess risk? I actually printed off this nice little checklist, which I will send to you to send out, that you can use to begin thinking about how do you assess risk in suicidal patients. So what are some of the things that you think about? Yes?
Have they attempted before?
Right.
Do they have a plan? Do they have a need that they have a plan?
Mm-hmm. So what if they've attempted before and they start telling you, yeah, I've tried to kill myself probably 20 times, and you start trying to figure out, you know, what were those attempts, and it turns out you have a cutter. How do you differentiate whether it's a suicide attempt or whether it's the attempt to get somebody else's attention? You know, how do you figure that out?
Did you ask them if they made, like, when you were thinking about suicide, did you attempt and someone stopped you, or did you make a call saying, I think I'm going to kill myself, so I called 911 or I called a friend?
Okay, so trying to figure out the intent behind or how they set it up to see that, absolutely. That's one of the things to think about. What else might you want to know? Getting comfortable asking people about self-harm, particularly there's a whole, the internet is full of the cutters groups and the burners groups now. And I mean, it's becoming very popular in kids, which is just mind-boggling to me and very sad. But there's a whole group of people who cut to release pain. And almost to the person, if you ask them, why did you cut? They'll tell you, I cut to relieve pain of some sort. So they really weren't cutting to kill themselves at any point. Most of those people have a pretty extensive abuse history and lots of bad things going on in their life. But that's a scary group of people to take care of, because when you start looking at some of the diagnoses associated with the cutters, which I'm assuming most of you have met some of the borderline personality disorders in the hospital because they get admitted to the medicine services quite frequently. You know, that group of people have an 11% increased risk of actually killing themselves at some point. So I can tell you one of the patients that I took care of who ended up killing herself, I know had no intention of dying that day because she was a horribly abused lady who kept taking overdoses on the way to her therapist's office. And one day she didn't show up to her therapist's office, and they found her naked in her bathroom. And I promise you, if she had tried to kill herself, she would have never been set up to be found naked. That would just not follow. But I think what happened to her is, you know, it was just one too many times of taking extra, she took extra Geodon a lot, and her heart just couldn't handle it. So these people accidentally kill themselves as well. And so one of the things when I started in psychiatry, I was always afraid to actually document a risk assessment. Why I thought this person who told me that they really want to kill themselves for, could really not have to be in the hospital. And again, I'm not saying you guys have to know that level, but I do think you have to know when do you need to send them directly to the hospital, when can you let them go home with their significant other or family, trying to help out, and when do you just, have to sort of go, okay, I'm not going to overreact. Because there are a group of people that the way that they ask for help is always, I'm suicidal. And I think some of that takes experience. You'll be doing this for a good long time, and you'll get to know, after you've done it a few years, you'll start seeing some pattern. But I think the other thing is knowing the patient. And do you have a therapeutic relationship with the patient? Again, I think somebody who comes in and tells you for the first time that they're wanting to kill themselves versus this is the 10th time you've seen them and they've said that, not that you don't take it seriously each time, but your ability to figure out, okay, what has happened, is this more risky now than it was the last time, changes based on the relationship you have with the patient. So past attempts is a big one. Intent plan means, finding out if they have firearms in the home, and if they do, getting those removed, preferably not by the patient but by somebody else. Do drugs and alcohol play a role in their life? As we know, drugs and alcohol decrease some of our best thinking skills from time to time, and people are more likely to do something they wouldn't normally do. Anything else you guys can think of? So what do you think about the thought you might have a suicidal patient in your office, and what are you going to do with them? Does that stress you out just a little bit? Are most of you guys planning to practice in the city, or anybody going out sort of in the country? Because I'll tell you, I'm not from Kentucky, but I'm from Indiana, which is not that far away. In the small communities in Indiana, there are no psychiatrists. So it is, the internal medicine doctors are pretty much taking care of all but the sickest of the sick. And they're definitely the ones who are trying to figure out what to do with the patients who come in suicidal, because there's nobody else to ask. So I think for anybody who's going to be in a smaller town, having some comfort with this group of patients is probably important for your practice as you go along. So I left some time for you guys to ask me, what kind of questions do you have about caring for depressed, anxious, whatever kind of patient, psychiatric patient comes into your office? Yes?
Some dumb questions for you, but I always heard, I guess, from med student on it, that if you were to assess risk, that it's okay, instead of asking, are you thinking about hurt, instead of sugarcoating and saying hurting yourself or hurting others, that it's okay to ask, are you thinking about killing yourself? And that the fear initially is that you're suddenly putting that seed into somebody's mind who didn't have it, but that it's actually more appropriate to ask specifically that instead of like beating around the bush. Is that correct or not, or is it wrong?
That is correct. I think that it's sort of like with any part of patient's history, if you ask it sort of matter of fact and put it out there, I think patients are willing to answer. It's sort of like the sexual history that everybody gets all freaked out about. You just have to ask the question. So I always ask, do you have thoughts of killing yourself? Because to me, there are people who will always answer, yes, I have thoughts of hurting myself. I think of that every day. So tell me the difference. So theoretically, suicidal ideations is actually killing yourself. It's not burning yourself or cutting yourself or any of the other things. So I'm more an out, sort of forthright, just ask the question. I'm sure there are other people who scurry around it. I don't really scurry around much of anything because it doesn't do anybody any good. And I think that if you're uncomfortable asking that question, patients also know it, and so they're uncomfortable answering. I think the flip side to understand is there are a lot of people who plan on committing suicide who are not going to tell you. And those are the ones that you're just sort of like, I just don't know. The ones who come and ask for help are the ones we can really help. Some of them that we see from time to time, we have a pretty good inkling that they're going to go do something, but we have no way to keep them from doing it. So a lot of times they end up in the hospital for the 72-hour hold, and then we have nothing, they're the perfect model citizen on the unit, even though we're all worried about their risk factors, but because of all the other legal things and people's rights and freedoms, they end up being discharged. And so it goes back to you do what you can. I think an interesting thing that I had never considered as a medical student that I probably spend more time thinking about now is for some people their mental illness is a terminal illness. The lady that I had who killed herself, I actually knew that she would die at some point for lots of different reasons in her life. And so sometimes my treatment is prolonging life in the same way that if you're going for chemo for your cancer, it prolongs your life as well. And I didn't think of that when I was in medical school. I thought, people are depressed, you give them pills and they get better. And there are some people who have a very chronic mental illness that don't get better, and sometimes what we're doing is prolonging. Any other questions? Yes?
I know there was some literature a few years ago about in younger patients, kind of the adolescent age group, that use SSRIs, that then they might have a higher risk for suicidality. I was just wondering what people are saying about that now and kind of what age limit that goes up to.
It doesn't really have an age limit. It actually is across the board. I mean, they noticed it more in that it came out of adolescence, but it actually is for all ages. Because what happens with the SSRIs is the symptom of sort of lack of motivation or wanting to do anything gets better sometimes before the depression actually gets better. So there's a group of people that it's almost like the increase in serotonin also increases they're activated in a different way, which makes them more likely to act on their suicidal thoughts. And we know that's still true. That's a risk in starting SSRIs. It's sort of, it needs to become part of your risk spiel that you tell the patients that you're going to start on these medications, the same as, your headaches or GIs. For some people, antidepressants can make their depression worse or can make them have suicidal thoughts. It's like you listen to the Chantix commercials and some of those. It's like, you have to come through this little spiel of the things you make sure you cover so that you say to your patient, if you notice you're having those thoughts, particularly for those patients who've never had them before, it's really important that you call the office and let's get you taken care of in a different way. But yes, that's still an ongoing risk. Yes?
So I have a patient that I actually brought to EPS who he has a lot of tendencies that seem like the bipolar.
Mm-hmm.
And angry all the time. And he was very depressed and very sad and actually agreed to let him start medication on him. And then wouldn't commit to saying he was suicidal. He said, I just don't know what I'm going to do. I'm very overwhelmed. And he wouldn't say, I've been thinking about killing myself, hurting myself.
Mm-hmm.
And I just didn't, and he was agreeable for me to start something. He wasn't agreeable last week to do EPS. But I was afraid to let him go too. We had this big discussion. One, he wasn't really saying he was suicidal. And if I had security take him down the EPS, I'm pretty sure it would be like tackling the lawn man.
Mm-hmm.
He was huge.
Mm-hmm.
And then he's got, I think he's probably bipolar. I didn't want to put him on a tricyclic. An SSRI probably wouldn't be a good idea either.
Mm-hmm.
If I can't get him to go to
A mood stabilizer.
What would you start with?
If he has more depression, I would probably start him on Lamictal. Particularly people with a real irritable depression, Lamictal does a lot of really good things for them. Now again, if you think he's angry and impulsive, then the primary mood stabilizers of lithium and Depakote are probably better choices. But if you think, wow, I think this is an irritable depression, then Lamictal's a good choice. Yes?
What kind of resources are available, like from the university or just in the city that we may not know about?
Okay. So there are lots of places in the city who do counseling on a sliding scale basis. So that your patients that you know are sort of in messy life situations, that can be helpful. And you can actually walk through the clinic at the ACB and just ask for one of the papers. And I mean, we just make copies of them all the time and hand them out. But that's a really nice resource when you need somebody needs somebody to talk to, and you're sort of like going, I'm not it. I'm not the person that can fill that role. Obviously, we know most of the homeless shelters and the substance abuse shelters. There's also some places for the chronically ill, mentally ill, which Bridgehaven has a day program for people who have schizophrenia or who have some pretty bad depression issues that they struggle with getting out of the house, so they work with those patients to really get them activated. Obviously, there's a million trillion different kinds of therapy because we're in the city, so there's art therapy, there's music therapy, there's yoga, there's massage, what was that place called? Safe Touch Massage, where they help PTSD victims, which I thought was a little strange. But, some of the cool things that are coming up, there's a lot of new virtual reality programs that work with people with anxieties or PTSD. We actually have virtual reality programs in our department. And if you ever want to play on it, it's sort of a cool thing to see what they do with the veterans as they come back from war and stuff, and how they work through the systematic desensitization is the fancy shrinky term for that, of helping them try to get back to their lives. I'm trying to think, obviously most of the people in town use 7 county services because that's our community mental health agency. As services continue to be cut, it's getting harder and harder to get people access to care. And so I don't have great answers for that because it seems like just when I find a place that I think, oh, this is a really pretty good resource, then it changes because they got funding for a year and then the next year they're not funded. We're working on, what we can offer in the ACB. As you know, probably with your own AIM clinics, there's just so many patients and only so many of us and so many of you that the need far outweighs what we can actually give. And one of the things that I've been pushing in the ACB is that we really try to take good care of the patients we get. That if we can help the people that we commit to help, that's better than taking everybody and not helping anyone. And sometimes finding that balance is very, very difficult within this system, as I suspect you guys struggle with as well. Because I've called the AIM clinic before. It's difficult to get patients in sometimes. But if you ever needed anything, also, most of the residents in the ACB clinic would be more than happy to at least try to help you figure something out. We know that our system can be confusing in the same way that sometimes referring into the main medical system can be confusing to us, that insurance is crazy for mental health care. Sorry about all the blocks onto your integrity. Most of the insurance companies have separate carriers for their mental health benefits, and you have to go through this whole nother path to even get appropriate care done. And we don't make any of those rules, but we live with them most days, so we can usually help you figure out how to do it. Anything else? Yes, ma'am.
Can you tell us when it would be
Well, that's a funny question. You mean like a patient in the hospital or just a patient?
If you're in the outpatient setting and you have a patient that you think is suicidal and they really need help, but they're not willing to go anywhere, or something like that, or they're acutely psychotic or something. I mean, I don't know if you use mental health or if you just call somebody. I mean, how do you get that person where they need to be?
You pretty much have to do a mental inquest warrant if they won't go voluntarily. So according to the law, which sometimes people enforce around here and sometimes they don't, if you're in the ACB, you are not in the hospital, so you cannot place somebody on a hold. As soon as you walk them across the way and you're even in the lobby of the hospital, theoretically you then as a doctor can place them on a hold and they can be detained, which makes no sense since our buildings are attached. So sometimes people place people on holds in the ACB and security will send them over to EPS. And then sometimes they'll say, no, we can't do that. So theoretically they can't do that. A lot of times, again, you use your resources if the patient has family members or different things. So it is not the best use of your time to go down to the MIW office and take out an MIW. However, if you really believe somebody is going to hurt themselves or hurt someone else, and you can't get somebody from their family to either take them to the hospital or go take out the MIW themselves, you have to go file an MIW. As most of us, I try very hard to never do that. It kills your, obviously, doctor-patient relationship most of the time. Most of the time that I've been in that situation, I've been able to talk one of the family members into sort of going, this is going to happen either way. Can we get them over to the hospital? But yes, the other thing to realize is in each state, the process for that is much different. And so if you move across the river into Indiana, their process is totally different than the process we have here in Kentucky. So wherever you finish and end up practicing, you need to know what is the process for involuntary commitment. So that's not a great answer because I know no one wants to go do an MIW. I've done one, and it turns out that if they're not in this county, you can't do an MIW on them either. So I sent the police to the guy's house anyway because he had a gun and was hopped up on something and was shooting like at people because he was paranoid through his house. So I figured the police would be willing to go pick him up for that, which he ended up in the hospital, but which is probably better than jail in the long run for him. But it's a sticky situation. So a lot of times what I say is, again, make a friend with a psychiatrist that you can just ask. But we do have obligations as doctors for the greater good. And so if you really think your patient is going to do something to hurt themselves or others, you are obligated to go and fill out the MIW. Any other questions? Very fun. Thank you very much for participating. I appreciate it.